The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Welcome. It's Saturday noon, and we are gathered here for the next episode of TMD Demystified live stream. I'm Tony Urbanek, and today we are going to touch on two topics, but I'd like to remind everyone who was watching that you're encouraged to ask questions, make comments, and even criticize if you'd like. And you don't have to wait to the end of the presentation or my speech to ask a question or make a comment. I have my eye on the live viewer chat, and I would prefer to answer questions as they come up. So, and I hope I stimulate some questions because there should be a lot of questions because there's so much confusion about TMJ in our society. And I put the live stream on in addition to my weekly podcast and my weekly blog to give the public and my doctor colleagues opportunity to question and comment about this problem that pretty much everyone thinks is a conundrum. Conundrum, totally unable to determine what the facts are and totally confusing. And after I did research on this issue, now 16 years ago, it became apparent that it shouldn't be a conundrum, it shouldn't be complicated, and the dental profession continues to want to make it complicated. We'll touch on that here again in a minute, why they did, why they shouldn't have, and why that was actually pretty dumb for them to do. And I say them, the dental profession, actually the ADA, American Dental Association, has, according to the American Dental Association, in March of 2020, approved the application for specialty for orofacial pain, making orofacial pain the 12th recognized specialty of the ADA. You know, like I'm an oral and maxillofacial surgeon and spent extra time after dental school. In fact, I went to medical school in addition to dental school, and then extra time training as an oral and maxillofacial surgeon in a hospital internship and residency. And in my case, I also spent additional time as a fellow, research fellow with the National Institute of Health, National Institute of Dental and Craniofacial Research. So, you know, you can put as much time into any topic as you want, but my point of view and what I have to say about this is that TMJ, which is the catch-all phrase, the name of the joint, it actually indicates how much confusion there is out there. Everybody calls this TMJ. Everybody has two TMJs, temporomandibular joints. Proper name could be temporomandibular joint disorder, temporomandibular joint disease. But my point is that we're going to touch on two topics. One is the one I had planned for today, which is what really causes TMJ, TMD. What is the cause? And as many of you know who follow me, that my topic for a week is first published on a blog, which can be seen on our website, www.urbanektmj.com. Usually about 2 pages that I write out my comments, the information, the data, the facts regarding a particular topic regarding TMD. And I believe last week we did the 196th episode article on the blog. And then the podcast, which is published on Dental Town and YouTube, last week was the 264th. And both of those were entitled What Really Causes TMJ or TMD? What really causes the problem? And today I'm also going to talk a little bit about the past episode of what is the real paradigm for this problem. Changing paradigms. The universe is working under an old paradigm. The dental schools are operating under an old paradigm. 99 and 44, 100% of dentists are working under an old paradigm, and the paradigm actually has changed. And I have developed and uncovered that paradigm, which is extremely simple to understand, extremely simple to apply. But let's go through the major part of this topic for today is what really causes this thing that everybody calls TMJ. Now, there's an old bit of research that was done by one of my oral and maxillofacial surgery colleagues back in the late 60s, I believe 1969 when it was published. Could be wrong, it could be in the early 70s, 73, 72, but I believe it was a 69, Dr. Danny Laskin, who is and was an icon in the specialty of oral and maxillofacial surgery and chairman of the Department of Oral and Maxillofacial Surgery at Illinois University. He, in the early time in research having to do with this problem that was being looked at by many different doctors, specialties, and as an oral and maxillofacial surgeon, he saw these patients with these disparate symptoms: headache, earache, jaw pain, neck pain, ringing in the ears, feeling of fullness in the ears, dizziness, upper back and shoulder pain, arm, hand, finger tingling and numbness, and various kinds of jaw locking. Of course, lots of noises coming from the joint. And he wrote a paper back in 1969, had it published. I actually have an original copy of that paper. And it is entitled, to paraphrase the title, The Myofascial, not facial, Myofascial Pain Dysfunction Syndrome Theory. It was his theory as to what caused all of these disparate symptoms. Myofascial pain dysfunction syndrome theory. Because of syndrome, because you had all these separate kind of funny symptoms that didn't make sense when you tried to put them together. And basically the explanation that he came up with is it's a muscle problem in the fascia around the muscles. When the muscles are overused, when the muscles are overused and get tired, they cause pain throughout the fascia, which is the covering of the muscle, and that is what creates the headaches and the jaw pain and the neck pain, etc. Well, it wasn't a bad theory for 1969, and I certainly would not criticize Dr. Danny Laskin for trying, but he didn't get it right, and he didn't really get into the information that was already out there and available and known by his and now my orthopedic colleagues. My orthopedic colleagues and his orthopedic friends knew all about the real mechanism for causing facial pain. Of course, orthopedic doctors don't really want or know anything to do about facial pain. That is not in their area of expertise. On the other hand, I've said many, many times, hundreds of times, if the orthopedic surgeons had kept control, wanted control, did the research regarding this joint, which is the only joint in the body that the orthopedic surgeons don't treat. This joint, it's the only joint in the body that the orthopedic surgeons don't want anything to do with, because I assume, my assumption, this joint is attached to the jaw, mandible, and the mandible is attached to the teeth, and it must have something to do with dentistry because it's attached to teeth, so I don't want anything to do with it. So they gave it away to the dental profession to figure out. Figure it out, doc, because we are orthopedic surgeons. And if the orthopedic surgeons had kept track of it, had tried to figure it out themselves, it would have been easy, and the treatment would have worked out much easier, much better, much faster over the past 50, 60 years. Now, I've talked many times about what really is the method that creates all of these symptoms. And it all starts out with chronic inflammation within the temporomandibular joint. Chronic inflammation is what I discovered in the literature already, in the tested literature, in the literature that has been around for better than 70 years. In fact, the first article that I uncovered that had to do with it went back to 1906. And that mechanism is a very simple mechanism that has to do with when you have a damaged joint of any kind, any joint, it sends a nervous signal through the autonomic nervous system to the brain and announces it's inflamed. You're not aware of this signal going on. It's an autonomic signal. It's the same kind of signal that keeps you breathing, keeps your gastrointestinal area working, keep your heart pumping. That's the autonomic nervous system. You don't have to think about these things. And when the brain, actually specifically in the lower parts of the brain, in the brain stem, the reticular formation, get this signal, it gets this signal, modulates it, indicates it's there, and sends a signal outward immediately to try to help that joint that's signaling it's inflamed, it's damaged. And the signal is to the muscles that move the joint, holding the joint still, telling the muscles to tighten up, become tight, become rigid, tighten up, don't move the joint. It's trying to help it, heal. The more you move a damaged joint, the less likely it's going to heal. And this is all going on without your knowledge. That is the mechanism. And when those signals come down, they don't necessarily always go to the right muscles, to the correct muscles, or they go to different muscles. And that's why the pain moves around the face and the neck and the shoulders, because it's getting these signals. I'm inflamed, I'm damaged. And first it says don't move the jaw, sends the signals out, autonomic sympathetic portion of the autonomic nervous system. Tighten up the muscles that move the mandible, then tighten up the neck muscles to tighten up, and then it says tighten up the entire upper shoulder girdle or the upper shoulders, and patients constantly complain of upper back and shoulder pain and tightness associated with inflammation in this joint. So Danny Laskin, bless his soul, he has now passed, made a good attempt. But the old paradigm was operating under Danny Laskin's theory. Doesn't hold water. It's not correct. But that's where we are. That is the old paradigm, and it's all based on that. It's also based on smoke and mirrors and a sleight of hand, actually, trying to define these symptoms as separate diseases. And I'll talk about that here toward the end as to what's going on there. Because this disease, temporomandibular joint disorder, is actually a very simple disease. It's the same disease as tennis elbow. Tennis elbow operates just like temporomandibular joint disorder. when the lateral epicondyle of the elbow gets inflamed and damaged because of too much repetition of the forearm. The complaints from the patients are not necessarily, if you push on that, it will hurt, but their complaint is pain of the entire forearm into the wrist, which is the exact same mechanism that occurs with TMD. A signal is sent from the lateral epicondyle to the brain, and the brain gets a signal, says, I'm inflamed, I'm damaged. The brain says, don't move that joint, and sends a signal back down through the sympathetic portion of the autonomic nervous system to all of the muscles that move the elbow, which are in the forearm. And when those muscles get the signal to get tight, those muscles tighten up to try to not move the elbow. The muscles pull on the periosteum, which is where they're attached to the bone. Muscles to move the bone, the forearm, the muscles have to be attached to the bone. And where the nociceptors, the pain receptors, are attached in the periosteum, the covering of the bone, where those muscles are attached to the bone is where it pulls on the bone excessively, stimulates the nociceptors, the pain receptors, and the signal goes back up to the brain and indicates pain in the forearm, just like pain in first the jaw, then the neck, then the shoulders. This is the mechanism. And in 2026, and the date today is August 15th, 2026, 99 and 44 100% of dentists are operating under the wrong paradigm, and 99 and 44 100% of the dentists who are supposed to be treating this problem don't know what I just told you. They are not aware of it. There are a few who are doctors who have learned through my efforts how to treat this by unloading the joint with a properly designed little device. We call it a tool. If you use the tool correctly, you'll get the result. And what does this tool do? This tool unloads the joint. If you have a damaged joint, the first thing you do is unload it. That's why an orthopedic surgeon, if you have tennis elbow, the proper treatment is to put the patient in a sling. Put the patient in a sling so he doesn't move the elbow. That is the proper treatment for an orthopedic surgeon for tennis elbow. If you have a damaged knee to the point that you might need knee surgery, well, if you don't want knee surgery and you don't want injections, the proper treatment then would be to the orthopedic surgeon to give you a set of crutches. And he would be absolutely correct in telling you that if you get on these crutches, if you stay on the crutches, your pain will go away and stay away as long as you're on the crutches. And that is why this little tool works so well. There is a protocol that goes along with this. The protocol is very simple. You have to start out very strong and begin 24/7 for 2 months, and then nighttime only, usually for the rest of your life. All you're doing is unloading the joint by unloading the posterior teeth over a period of time according to a protocol. You have to be somewhat cautious, but over the first 2 months of 24/7, you cannot get movement of the teeth that are not supported in an adult, different in children. But in an adult, you do not get super eruption, you do not get movement of the teeth. For the biggest reason is the patient has to eat at least a couple times a day, and they're chewing on those teeth. But you are unloading the joint because 90% of the loads on the temporomandibular joint come from the back teeth, the posterior teeth, posterior occlusion. 90%. So if you unload the posterior teeth for a while, the inflammation will die down. The whole game is to get the inflammation down to the point where it quits sending the signals, I'm inflamed. That chronic inflammation signal. And then actually the chronic inflammation will diminish. If it doesn't diminish, then it will go on to continue damaging the joint to create additional signals that I'm damaged, I'm inflamed. And it's a progressive disease that can go on for decades, unrecognized, mainly unrecognized and called something else, like migraine headaches, Meniere's disease, and ear infections. So that is the old paradigm versus the new paradigm. Old paradigm versus a new paradigm. So what is the real cause of the damage to the temporomandibular joint, which is actually the title of today's live stream? What is the real cause? Well, the real cause are three. I'm going to share my screen and we'll talk about this. If I might. There are three causes. One of them is the one that most people are aware of, which is bruxism. But even the dentists think that that's the only cause, bruxism. Well, it's not the only cause. There are two others. It is the primary cause, which is bruxism is nothing more than clenching and grinding. Can do it in the day, can do it at night. You don't have to make noise with your teeth. You don't have to move your teeth around. It can be a clenching with no motion at all. But that mechanism, then once the joint is damaged by overloading the joint by bruxing, clenching and grinding, you can secondly overload the joint with acute trauma of various kinds. The most common one that I have seen, and I believe it is in the literature as the most common traumatic cause, is motor vehicle accidents, especially whiplash. But you can have athletic accidents, falls, hitting the face, all kind of different things. Bar fights, falls off in Tennessee, falls off of horses. Horse accidents are extremely, extremely common. Surprised me when I came to Tennessee to see how many horse accidents we have. And then the third is functional malocclusions, where the bite, the teeth, way the teeth mesh or don't mesh incorrectly will overload the joint. And so what all three of these have in common is simply they overload the joint, either acutely, a one-stop and one incident occurrence, which is acute trauma, or over a period of time, which is bruxism and functional malocclusion. But those are the only causes for damage. And there are neoplasms and other things, but I'm talking about damage to the temporomandibular joint. There are three categories. And those categories damage the joint once the joint is inflamed, whether it be a TMD, temporomandibular joint, or whether it be a hip or an elbow. Once damaged, the body goes on to create inflammation in an attempt to heal. But if it doesn't heal over a reasonable period of time, that healing inflammation turns into chronic inflammation, which is a different cell type, and different cellular exudates and chemicals, biochemicals are secreted, which then will be very destructive within a joint. And that's when you get destruction of all the other tissues within the joint, destruction of the meniscus, the disc, destruction of the synovial fluid, which is the lubricant within the joint, becomes a different characteristic under the influence of inflammation. The synovial membrane is rapidly destroyed. I know this visually. I've operated on over 2,000 temporomandibular joints in my earlier career as a maxillofacial surgeon, and I've seen this visually, whether it be through an open incision into the joint or through an arthroscope looking inside the joint with a camera and looking at the surgery on a television screen as I operate the joint. But once that chronic inflammation gets hold, then you're on a slippery slope, and it keeps sending out signals. I'm inflamed. The signals come down, tighten up, facial muscles, neck muscles, shoulder muscles. I even have a few patients who ended up in the emergency room because they thought they had such severe chest pain that they thought they were having a heart attack. That has been documented. I've documented that 3 times with 3 separate patients. So that is those that is the actual cause. The three categories of cause to damage a temporomandibular joint, but the common denominator of it all is chronic inflammation. And if you can make the chronic inflammation go away, then all the symptoms go away. You don't have to have any other treatment. You definitely don't have to treat symptoms. You're treating the cause, which is chronic inflammation within the temporomandibular joint. So, but unfortunately now, with the wisdom or lack of it, with the American Dental Association, they have, I believe, at the insistence of a small group of doctors who I call TMD gurus, who pretty much treat this with smoke and mirrors and voodoo, and definitely limit only to trying to treat symptoms. At their insistence, as I said earlier, the American Dental Association approved the application for specialty for oral facial pain, making oral facial pain the 12th recognized specialty of the ADA. And then what I have picked off the internet here, and I'm going to read this as we finish up this episode. Oral facial pain covers several general areas that are not addressed in detail by any other recognized dental specialty. You don't have to have it recognized by a specialty. Once the dentist understands what I just told you, that's all he needs to know is how to treat this correctly. But let me go on. The 7 tenets or portions of oral-facial pain include temporomandibular joint disorders, neuropathic pain like trigeminal neuralgia. Well, neuropathic is just a catch-all phrase, as is trigeminal neuralgia. My medical colleagues admit they have no idea what causes migraine headaches or trigeminal neuralgia. Trigeminal neuralgia, as I said, is a catch-all phrase. It has been considered a separate disease only because nobody could understand it. But trigeminal neuralgia is nothing more than pain associated with the trigeminal nerve. And where do these autonomic nerve signals go up and down? They use the trigeminal nerve. So, the tenets that the specialty is claiming are separate diseases, neurovascular pain like migraines. That's one of the theories of a migraine. It is neurovascular. Well, yes, the signals of the autonomic nervous system that I described actually go up and down the nervous tissue, the nerves, which are closely associated with the vascular or vessels in the area, but that doesn't make it a separate disease. It only makes it where the signals go up and back and up and down from the area of the joint that's damaged to the brain and back down to the muscles that are being told to tighten up. So you have an absolute confusion from the standpoint of what now is a specialty, or claimed to be a specialty, that is totally unneeded to understand and treat this disease. You don't need to be a specialist, and you definitely don't need machinery to diagnose this problem. Believe me, if your doctor comes at you with a stethoscope, listening to your joint noises, trying to make distinctions between the different kind of joint noises, he is definitely wasting his time. Yes, the joints do make noise, no doubt about it. A damaged joint will make noise all the time, every time, because the ligaments that hold that meniscus or disc or cushion in place become loose under the influence of what? Chronic inflammation. That also causes locking. When that disc gets loose, the disc gets in a position where it impedes the proper motion of the mandible. And when that happens, when you go to open, you bump into your own meniscus, your own cushion, because it's out of place and you can't open all the way. But that doesn't make it a different disease. It is a portion of the same disease, which is chronic inflammation within the temporomandibular joint. I think that I have done the best I can for today to describe what really causes TMJ, which is three things, characteristics of damage: bruxism, acute trauma, and functional malocclusion, where your teeth or jaws, it can be the teeth not fitting together, or it can be the jaws totally cattywampus, where the jaws don't fit together correctly, all of which can be corrected, by the way, with a combination of orthodontics and sometimes surgery if you have a growth problem of the jaw. Remember, I spent 2 years doing nothing but study facial growth and development with the NIH NIDCR. So that is what the three characteristics or causes of, and I think we adequately covered the change in paradigm that is necessary to understand this disease. The doctors, the dentists, are not going to be able to treat this disease correctly if they don't understand how the disease works. And what I just went over with you, what I just described, and it's not the first time I described this, is exactly what creates all of the symptoms. And then if some of you out there are thinking about the non-painful symptoms, that's a different mechanism, also caused by chronic inflammation getting into the middle ear. And that's been described before, and I refer you to earlier episodes, both of the blog, of the podcast, and even the live stream. I've talked about how chronic inflammation can get into the middle ear, where the hearing mechanism and the vestibular mechanism are, to damage those mechanisms, causing ringing in the ears, feeling of fullness in the ears, and dizziness. All right, I believe we're out of time. I have not seen any comments on live chat as of this time. So we'll get it published. I hope that for those that do see this in the recorded version, that it's meaningful, that's helpful, that you can use it. If you're a dentist, you can use it in your practice. If you're a dentist who'd like to learn how to do and use this device, which is patented, you can look at our website. It gives you the invitation on how to become a network provider and use this patented device and protocol for the treatment of your patients who have had, many of them have been misdiagnosed and have been run around in circles for this problem, for some of them decades. Or if you are a patient, you can go to the same website, www.Urbanek TMJ, and you can get the list of doctors who have already been licensed to use this device and protocol in your area. With that being said, I look forward to next Saturday at noon when I'll sit down and do a brief 30-minute presentation about TMD Demystified live stream. I am Tony Urbanek.